This talk I've given before to residents, so if it's a little bit not in depth, maybe next time we can change that. So no financial disclosures. Videos here are just public domain videos. They're not any patients of ours. Although if I do this talk again, I've kind of been in talks with people about getting consents about local patients who've got all these diagnoses, and I think that the videos might be instructive. So we have some objectives. They're sort of the vague objectives usually when we cover any sort of topic, to define it and to describe it and kind of increase our clinical judgment in terms of likelihoods when people present to us with chief complaints or stories and ask for our opinion. I wanted to start a little bit about me, for people who don't know me at all. I am from this place, Ragley, which is halfway between Lake Charles and DeRidder, and this is probably the biggest building in Ragley. That's the barn behind my house. And so I grew up on a farm there, and there's nothing else there besides this picture. And then that's not a financial disclosure. That's Dad's crawfish. I'm not asking anyone to purchase any. But I did my undergrad training in Baton Rouge and then went to LSU Shreveport, like I was just talking there. And then did pediatrics. So the way we do this, we do 2 years of pediatrics, and then we do an adult year, and then we do child neurology, and then I did an additional year in fellowship for epilepsy afterward. And that's all at Arkansas Children's in Little Rock. We did epilepsy surgery, etc. there. This is an artistic rendering of the Transfiguration. This is Raphael, but the point of this is that this little person here depicted in this is a child with epilepsy from a biblical story, and this is probably the prettiest epilepsy picture that I could find. So basically in pediatric epilepsy, most people who present with epilepsy or who are treated in terms of numbers, kids tend to see a lot of, have a lot of seizures, and most epileptologists are pediatrics in general. And so there's a few differences in childhood epilepsy versus a grown-up epilepsy. In children, a lot of times it's a genetic situation or epilepsy syndrome, which may be outgrown. Whereas if you are new onset epileptic as an adult, you're unlikely to grow out of your seizures. Your seizures are likely to be caused by some secondary cause, stroke or previous trauma or lifestyle risk factors that have accumulated. Children are more resilient than grown-ups. So you can see here they can have quite a few seizures in a day, and they just tend to, they do very well. They can have many, many seizures, and we've probably all seen patients who have been refractory and who have had many seizures. There's also additional concerns in children. Epilepsy in children will affect their development, their learning, depending on how many seizures, their general EEG picture, and where they started. So a lot of kids with epilepsy also have delay, and this sort of derails that even further. In grown-ups, that's probably just underdocumented because we don't talk about development in grown-ups, but it's probably more speeding the onset of memory loss and that kind of things in uncontrolled epilepsy. So the definition of an epileptic seizure, we call it abnormal persistent firing of neurons, which leads to some sort of change. It's not an exactly complete statement. Sometimes we have different, like ICU type seizures do not always cause changes, but we define them by their duration and how they look on our EEG machines. But in general, you want to see something that's repetitive and that correlates with what would be a known epilepsy pattern. So then there are some numbers. I don't know that those numbers have a lot of clinical bearing. This is just a picture of an EEG that's not normal. The high spikies are bad. This is good. So the definition of epilepsy is it implies a chronic condition that'll recur. So a first-time seizure, something that you can explain away. You got hit upside the head with something and seized immediately. You don't have epilepsy at that point. You have a seizure caused by something. Same thing with febrile seizures, hyponatremia, sugar related issues that Dr. Flint sees. And the treatment for those is not an epilepsy treatment, it's treating the underlying cause and provoking factors. And so the old definition was 2 seizures more than 24 hours apart. You're very, very likely to have more. You have to be treated. They changed it to where we can treat a lot of kids after their first seizure, and those kids have the same risk of a recurrent seizure person, and those are abnormal EEGs. But there are specific abnormalities that mean that. So just a simple abnormality like if it's technically an abnormal EEG, meaning it's slow, it's not as fast as normal, that would not imply epilepsy. And so usually we write words at the end of these reports to indicate that this would suggest epilepsy, or this is a nonspecific finding or something. This abnormal brain structure would mean if a child with cerebral palsy has a first-time seizure, they would meet this category. Their likelihood of recurrent seizures is very high and probably should be treated, or at least discussed strongly with family. I think some parents don't want to after the first seizure, but you should have that discussion, I think, at that time. So the highest incidence of epilepsy is right at birth, and then kind of continues in childhood, then drifts down in early teens and adulthood, and then peaks up again in older ages. And so when you get a new onset fulminant epilepsy as a teenager, that's very unlikely to be a regular epilepsy syndrome. That's not when those tend to present. So that should raise some red flags when someone begins with frequent long seizures as a teenager as opposed to a smaller person. And then all the syndromes have certain ages you expect to see them, like breath-holding spells. If a 15-year-old showed up at breath-holding spells at your office, you would think, this sounds weird to me. This is not normal. So this isn't a very cutting-edge new picture, but this shows you myelination and how the brain develops over gestational age. And so you can see the 20 and 22 and 24-week brains and how smooth they are. Their seizures look radically different than 2, 3, 4-year-olds. And part of that is the transmission mechanism in the brain is not mature. And so because of that, they're more likely to seize because their brain is not really meant to be out and about in the world. So they're more likely to have seizures, and those seizures are less likely to look like what you think of seizures looking like. So in the neonates and especially in the preemies, you should just, I think a high index of suspicion is best, and we'll show some videos of neonate seizures here. This is what I meant by basic, and if it's, just bear with me. But myelin surrounds the nerves, speeds up the transmission of the nerves, and as you develop, your myelination will progress in a normal pattern. And that progression will mimic childhood development. So at first, you're myelinated swallowing and sucking, right? Because that's what you have to do to survive. And as that progresses, your developmental milestones follow along with that. Children with delay have delayed myelination a lot of times. And it's not really a cause and effect as far as we know. It's just, I think, another way to see what you see with your eyes in clinic. The MRI also shows the myelination pattern is slower than you would expect. So this is just what an MRI looks like with a kind of a not very myelinated on this one, and then this is more of a normal myelination pattern. And I have a, oops, let's see, maybe I'll use this. Well, that just won't show. So here's a video, and I want you to see this video. I've never been able to figure out what this beeping sound is in the back of this. And so this represents seizure. So there's two ways we can talk about this. Sometimes I'll show the videos and make you guess because I have a seizure and I have a non-seizure. And this one is the seizure, and it's very subtle, and it's not very, kids do this all the time, you know, little babies especially with the sucking movements. The coughing and the yawning is not, but the sucking movements they were doing earlier is. This video no argument, kind of weird looking, right? And so I think that in this case, this child's getting an EEG, and probably for these movements. If you see a movement that occurs in a single extremity or a single hemi-body portion that kind of occurs over and over and over again, you should have a very high index of two things in babies. Number one is seizure, and number two is seizure because of a stroke. And so imaging is probably needed in that case. In this kid, this is not a seizure. And I would suspect over a 24-hour monitoring period, you would see that the other limbs would move here and there, and that this is just some kind of myoclonic behavior. But I don't think EEGs are harmful, and if you have a recurrent episode that you don't know, I think that this is easily solvable, especially if this recurs frequent enough to capture like they did in this study. So we're going to go over a little bit of some types of seizures and just some kind of vernacular. So semiology is the appearance. So when we say seizure semiology, it means what does it look like? And that is very important for us to try to figure out, do we think it's seizures, do we think it's not, and then what type they are. So seizures are very intermittent, and one benefit of cell phones, if there is a benefit to cell phones, it is that people can video strange seizures that you never get to see in clinic. And so they come talk to you and they say, Johnny did this, and you're thinking, you have no idea what they're talking about. And then they explained it a little bit. Well, he had some movements, and you're thinking, that's a pediatric clinic. I'm sure there's in the hallway people are running around doing all kind of stuff, and you're wondering, how do I discern? So film is very helpful, and film should never be deleted. So I get a lot of families who will film this, but then they delete it for something else, and they go see a variety of other specialists who never get to see the episode. And so it's very helpful for us to be able to see the video, and it's helpful for you guys too to know how alarmed do I need to be in what they're describing. So any information is very helpful in terms of determining the etiology, the focus, and what type of medicine we use. And I would argue what happened before the seizure is very important too. I would say 95% of epilepsy or non-epileptic events, either one, they always tell me the child is sleepy afterwards. So I don't know how sensitive that is. It's always like he did this and then he was very sleepy. But what happened before, what provoked the episode is very important. And they may not know, we may not know, because you may not notice anything's off until it happened. So this is kind of older terminology. The newer terminology is not as commonly used. Focal and generalized is kind of what's been used for the most occasions. And so focal means starting from one area, and it doesn't imply anything besides that. Focal means start in one area. Most people think even seizures you see that look generalized, they start somewhere and then they spread really fast. Simple means they're awake, no effect in consciousness, and then complex is alteration in consciousness. And to generalize, there's a whole lot of different types of generalized seizures, right? So there's jerking seizures, so the clonic seizures that you think of, kind of like this, and then tonic seizures, kind of with this posturing presentation, atonic, the so-called drop attacks, and then absent seizures. And then pseudo-seizures, very, very, very common, or non-epileptic spells, however you want to call it. Pseudo-seizure is kind of an archaic term we don't use too much, but it implies psychogenicity. It implies that some sort of psychiatric cause is what's happening. We don't really know what causes it. It's just not epilepsy. Non-epileptic spells I like better because it encompasses everything. If you have syncope, that's a non-epileptic spell. It's just a spell of some sort that is not epilepsy. And so I like non-epileptic spells because it doesn't imply judgment. I think pseudo-seizures are very often, you're faking it in the same sentence. And that's how people are presented with that, or their aunts and uncles were, and so then they have this kind of connotation. This slide is strictly to show you that seizures from these different lobes usually appear differently. So the type of focal seizure coming from the temporal lobe or the occipital, the parietal, the frontal, they all have different appearances. Those appearances, that's ictal semiology. There's a whole lot of people who really like ictal semiology, and they have whole conferences, like I'm going to one in New Orleans this year, and they'll have a big room like this, and they'll show a seizure, and then everyone debates on where it came from. And the point is not that's not very useful. The point is to realize that seizures can have a lot of different presentations besides absent seizures, which you see a bunch of, and generalized tonic-clonic seizures, which you see a bunch of. So the frontal lobe causes eye deviation. And eye deviation should be both eyes to one side or the other, and then the head. Because the same centers that move your eye will also turn your head. Okay, so you'll have eye deviation, then head deviation. And if it progresses longer, you'll probably have ipsilateral, the same side of the turn, movement. So that gets very suspicious for seizures. Not a lot else does that. This movement, head turning like this, is not an epileptic event. It just can't happen because it would be a seizure on one side of the brain followed by a seizure on the other. This seizure shuts off, then introduces another seizure. So a no movement is a very good, to me, it's a good finding for a non-epileptic event. So abnormal behaviors, think frontal lobe. What that means is the thrashing spells at night. Frontal lobe seizures will be brief, thrashing, a lot of movement at night. Very, very brief, 30 seconds. So screaming and yelling for hours and like having all these behavioral things, that would not be frontal lobe seizures. But it doesn't rule out that they're there sometimes, right? So many kids have nightmares, night terrors, and this is something to think of because when you think of that doesn't sound like a seizure at all, one of the possible culprits is a frontal lobe seizure. Preceding aura, nausea, fear, automatisms. Temporal lobe has a lot of different auras, and it just depends on where they come from. And this, I'll just say one little section about this, visual hallucinations. These are simple, light hallucinations, almost like a migrainous aura. They're very quick. You see a light. It's not a complex formed hallucination like evil friend or a dragon or something. And then you can even have auditory sounds, but those sounds tend to be not very well formed, not a whole sentence and command type thing. So when you have command hallucinations or very well formed hallucinations, epilepsy wouldn't fit. And if you have visual and auditory hallucinations, that's two different areas of the brain. So that would be two separate focal epilepsies, so your likelihood would go down quite a bit. But with kids, it's hard, right? Because some of their hallucinations are purely imaginative, and they'll hear things and they don't describe to, they hear a noise and then they interpret that to you in a formed manner to make it make sense. Like I had a kid who had a migraine aura, and she said she would see a ghost. I see a ghost and then I have a headache. And she wasn't seeing any ghosts, right? But she would see something and then would explain it differently. So these get complicated, okay? Because simple focal seizures, you really need the video, because if it's so focal, sometimes the EEG itself won't even show it, okay? Because you have to have a certain millimeter squared of the brain for it to generate the thing we're looking for on the EEG. Complex, the EEG should almost always be abnormal. So if the kid's altered during their episode, the EEG will catch this, especially if they have it on the study itself. Jacksonian march is very classic for seizures, which is basically a seizure begins in an area, maybe the hand, and then slowly progresses up to other areas. And that's all based on square footage area of the brain, basically. So face, hand, very much acreage, a lot of acreage in the brain in terms of control, and the seizure will present that way. So you'll have a lot of hand stuff and facial movements, and you'll have this very progression on one side. Jumping from one to the other would be not likely. It would need to progress all the way to the other, and then they lose consciousness when it crosses over to the other side. So as long as one side's involved, you can maintain some consciousness, but once it gets to both sides, you should be out. I'm going to skip the rest of that. Todd's paralysis, I think, is a very good tool. So after a seizure, some people will have paralysis or intense weakness of the area involved in the seizure. Not a lot else does that. You see some with some unusual migrainous type stuff, but if a child has some weird thing found down kind of thing and then wakes up and has weakness or dragging a leg, you're going to be scared of a stroke or something. You're going to send it to the ER and they're going to get imaged. It may be negative. But the thing to think about is they could have had a seizure beforehand. And this can last hours and hours. And so this may be what they present with. They wake up, they go see their mom, and they have that weakness. So you should think EEG too. It's always a hard thing. What else should I be adding to everything in the world I'm scared of when a kid wakes up and doesn't move their arm? But EEG is something to look at. It's a good video. So look at this eye. And look at this. When I first saw this, they had told me the eye was what to watch, but this doesn't look normal. You know, she's posturing this arm even. And I don't know, with little kids, it's hard to tell. This kid doesn't care. She's about to come steal this toy. Taking advantage of the seizure, making their move. But you can see it's not very, if you're in a school or a daycare, this is going to be missed a lot of times, right? The kid's quietly sitting on the floor, didn't fall over, and then looks normal. So I have a low threshold for EEGs because of stuff like this. Because parents will say, well, she was completely responsive, nothing happened, but they didn't notice the hand or they didn't notice the eye. And all those things increase your suspicion. And focal seizures are more worrisome than generalized in terms of other causes. They're harder to see and they're more worrisome. So what should I do? Imaging is the way to do this. MRI is the much preferred method. As we all know, there's resource limitations, timing limitations, sedation limitations, all these things in terms of getting a scan. So I would say quick seizure, bounce back. The rules are they don't have to have a CT. Lots of quick seizures, I would argue, need something. And MRI is the way to do it if you can do it. And it's easier said than done, right? But it's okay to get both. But I had a radiologist tell me one time that there's two indications for an MRI, and it's a normal CT and an abnormal CT. So either way, that's what we're going to do. I think labs are reasonable for focal seizures, and all these testings become more reasonable if the child is also altered. So if the kid has a seizure and then looks running around and everything's fine, that's not nearly as concerning as kind of this lethargic person who should be back to normal. So these are just descriptions of how we describe generalized seizures. There's not really a practical, a tonic seizure versus a tonic-clonic, or those, they don't mean anything in terms of treatment or prognosis, except tonic seizures tend to be more likely in children who have refractory epilepsy, tend to be happening at night. Some medicines may help better. Myoclonic are very challenging. They're the ones like when you're falling asleep and you have a quick jerk. That's a myoclonic seizure. But myoclonus looks the same if it's a seizure or if it's just a myoclonic jerk. So the way you would define that is usually somebody had a big grand mal seizure, and then you find out later they've been having myoclonic jerks when they wake up in the morning, when they're eating breakfast. And a lot of parents just describe it as clumsiness. They don't ever say there's myoclonus. They're dropping stuff, throwing stuff, and it's because their kid's having a seizure and spilling things, and no one really notices because it's so quick and the consciousness is pretty much not. Atonic, we have some video. We have video of atonic seizures, but the thing is about atonic, there's no warning. So any syncopal aura, nausea, lightheadedness, paleness, doing things like that, and then a collapse would not be consistent with an atonic seizure. You should have no warning, and you should drop, and you should regain consciousness very quickly. And absence, we'll talk about absence some. I think I have one video of absence seizures, but in general, you should expect dozens of these seizures a day. It shouldn't affect cognition a whole lot except during the seizure, so there should be no confusion and things, but they may have some trouble with school, ADHD type statements. But most kids I meet who are thought to be ADD and have found to have absence seizures, they really do have both usually. Once the absence is wiped away, you still have a very rambunctious, excitable person who doesn't like to pay attention, but he pays better attention now that he's not seizing too. This is a generalized seizure, kind of the tail end of one. And you see the blinking here and the facial movement along with the arms both together. And you can tell it's already slowing down some. Usually the arms kind of come up first, and then you have this very violent discoloration and things. And this is already going to have a few more twitches maybe as the end goes. Always remember to turn kids on their side if they have a generalized seizure. So you can always tell the atonic seizure people, because this is how they come to clinic. And I'll just let it play while we talk. So that was one, right? So it's, they just don't have a whole, the main problem is they bust their lips, they bust their teeth, they injure themselves during these drops. And some kids regain consciousness before they even hit anything. They'll just head nod. And that can still be atonic seizures. Most kids with drop seizures have other epilepsies that are already known, and then they develop these. So 2 or 3 types of seizures, atonic seizures, classic. Some of our NICU graduates, for example, who have lots of seizures, this is a common additional seizure you then develop. We treat these with the regular seizure meds. They're not easy to treat. Some kids get corpus callosotomies. We'll talk about that maybe a little bit later, but there are ways. This is a generalized seizure, just like a generalized tonic-clonic seizure, and on EEG it just looks like a generalized seizure. We don't know it's this until the family tells us or we see it on video. But see the difference in this and syncope, how many he's had already in this video? He's had several. And this kid is a known epileptic with this helmet and probably has several different medications. There are exceptions to everything I'm saying, okay? But in general. This video I have to let play a little while because I don't know how to make it. On my computer I can skip to the middle, which is where his seizure is, but his family's going to provoke an absence seizure in this kid, okay? So they're going to make him hyperventilate, and you're going to see one. And one of the key features to me of an absence seizure is the kid begins exactly where they were at the beginning of the seizure. They have no clue that happened, unless you're talking and they missed it, and they'll start catching up. The other thing to remember about absence seizures is the duration, okay? 5 seconds, 10 seconds, maybe 15. That sounds more like an absence seizure. 2 minutes, 5 minutes, 10 minutes, way too long, more daydreamy, okay? So also think about what scenarios families are seeing this. In absence seizures, I get a lot of people tell me he does it when he's eating, he does it when he's typing, he does it when he's doing a continuous motion that you can see when he stops for that short of time. So video games, very common, and that's not the cause, but you can tell if somebody has a 5-second arrest while playing a video game. But watching a movie, you can't tell. You'll be able to see. It's a minute in. So that's a very classic absence type picture, right? They don't even know. They just right back to blowing. And some of them will stumble and fall, and it's that phenomenon when you walk up and down stairs and there's an extra or less stair than you anticipated, and then you kind of stumble even though you don't have balance problems. When they're walking or going up the stairs and they have a seizure, their body's momentum has carried them into a different place than they remember. And so then they come up and they'll have this kind of jump phenomenon. So you want to know how long the spell lasts and how many of these they're seeing and what activities they're seeing it at. And I always tell parents, if you see it only in church, it's probably not absence seizure, just a daydream. But these seizures are almost 90-95% you're going to catch them on EEG, even if they're not seizing. So the EEGs are very, very, very sensitive in this. Generalized seizures are less likely to have a focal problem like a tumor or a bleed or something like that. It's more likely a genetic situation or a developmental problem. The issue is how certain are we all that it was a focal seizure or a generalized seizure? You don't know. But in absence, it's usually a benign finding. There have been examples of focal findings causing generalized seizures. No one knows how that happens, but it does. But in general, in these kids, I usually just recommend doing the things that you're going to do anyway. Check the glucose level. You're going to do some tests in a new onset seizure. But in general, you're less likely to find stuff in these kids. More likely to be inheritable, a genetic mutation, or something of that nature. I just put this at the end here because that's not really necessary for epilepsy itself, but in an intellectually disabled person or in a person who has CP, but we don't really have a good reason for them to have had that, you should think genetic or metabolic diseases that are fairly rare. So they'll look like a static encephalopathy perhaps with slow regression that you don't notice because it's so slow. And so some of those kids, I usually recommend different testing than I would kids who are developmentally normal. Febrile seizures, I won't talk too much about because I think you guys know everything about febrile seizures. But basically, we kind of categorize them into simple and complex based on age and other symptoms, okay? I will say seizures that occur at 6 months and ones that occur at 6 years are less likely to be just febrile seizures, even though that's in the technical list, and temperatures that are low, 100.1, these kind of febrile seizures, but you never would have done anything with that fever in your life. That's always a question mark for me. Like, was it a fever even? Or did they just get their temp worked up because they seized? I don't know. So 1 in 24 hours, less than 15 minutes, and generalized, you don't have to do any additional workup. Complicated means more than 15 minutes, more than 1, and focal. Add this to people who are developmentally not normal. So if it's a simple febrile seizure in a child with autism or cerebral palsy or whatever, then I would just go ahead and start this workup because their risk is a lot higher. The other kids are 8 relatives who all had epilepsy who required medication. I would do the workup on that child as well. If everyone has febrile seizures in the family, their likelihood of developing epilepsy is way lower than the general public. So this is a big question, a lot of things, and I think each society has their own recommendations. Lumbar punctures are indicated in certain ages, and they're indicated in certain clinical scenarios. I'll leave that to you guys, but I would say that if you have an encephalopathic person who doesn't fit a 30-second generalized seizure, you have to decide some of that. The fever's persistent, there's other findings. Sometimes this could just be a provoked CNS infection, right? So that's why they had their seizure, and so you use your judgment based on how the child looks. And it's easier said than done. One thing I'll say here is that white count, if it's elevated in your tap, is very unlikely to be because of the seizure. It can pop up some, but not very much. Same with glucose, by the way. So glucose will gum up too after a seizure. But if you have a 300, 400, 500 glucose, you should consider things, especially in overweight adolescents, teenagers, and things. I've had a few type 2 diabetics kind of present with just a big seizure. And hyperglycemia doesn't usually cause that, so I'm not sure how that fits into that whole mechanism. Usually it's hypoglycemia, but just consider when you have a lab abnormality and you're thinking it's because of the seizure, my general approach is repeat that when they're not having any of that problem and make sure it's normal. Except CSF, you don't have to repeat CSF over and over. So this is a good one. Epileptic spasms, also known as infantile spasms, 3 to 12 months. I would say mostly 6 to 8 months is when we see these kids. These are the ones, extreme premature babies, HIE babies. Keep this on your radar very strongly. Down syndrome is another group of kids. So it's more often in children who have some developmental compromise to begin with, but it can happen in completely normal developmental children. And so a lot of these epileptic spasms, they can also be very variable too. So I think the index of suspicion should be high. This is very important. Treating early is better than treating late. If we do an EEG on anybody you think has epileptic spasms, if the EEG is normal, I'm always going to recommend do another in 2 weeks. And it's because at the very beginning, the EEG can still be okay, and then it shifts. That's not very common, but it does happen. This EEG is unmistakably terrible, okay? And the only debate is what sort of kind of bad epilepsy do we have? If you don't see the seizure itself, then you're kind of confused in that category. But I've had kids whose EEGs look like they had spasms and no one had seen one. So then you bring them in for a full day of monitoring and their spasm is literally just a slight head nod, eyes up. That's it. In a developmentally normal kid, I've never seen that. I've only seen that in a delayed child who you had some suspicion, so you did the EEG and you see this and you're just waiting for the spasm and it never happens. With insurance the way it is, some of the treatments we have for epileptic spasms, we can't actually give them unless there's a documented, like I have to capture it and it has to be known for them to cover it. So there is some questions there with that. Associated with severe developmental delays, that's true, and there's a correlation even accounting for their pre-delay. So their delay before the seizures, the duration of how long they have the spasms before we stop them is related to their development afterward. But we don't know if it's certain types of brains who have both bad development or trouble with developing as well as hard to control seizures. You see here it often occurs in clusters. I find that kids often cry afterward. They get startled with it. This is the most common one I see. No, you're good. You're good. So EEG and referral, call us if you think things are taking too long. We can get an EEG in probably 24 to 72 hours in almost every case. And if they tell you that that's not the way, if they say there's not one available, you should contact me and we can probably make one available, right? So this would count as something that needs to be done. And the EEG in this case is actually more important than me ever visiting with them because I need to see this EEG quick because a lot of things sound like this. Try to get families to film it, especially if it's clusters, and we need to kind of step on it if this is something that we're concerned about. The general workup is trying to find a cause. So if you have a normal kid who has this, we need to look at an MRI. They may have schizencephaly, some sort of heterotopia, a malformation of some sort, which changes things. There's 3 treatments, okay? In the UK and over there, they do really high-dose prednisone. We've started to do that kind of in the US. Those are a lot easier to get covered and get done, and the results are pretty good, but the doses are pretty insane. I mean, we do 60 to 80 milligrams in a single day in an infant, and we do it for a few weeks. So it's pretty. Dr. Flint had a near syncopal spell when I was talking. She's the endocrinologist here, but she was like, "What? What are you doing?" That's no shots and it's liquid, so parents do like it, but my problem is there are lots of labs. You have this immunosuppression to concern yourself with. A lot of our babies who have genetic syndromes have congenital hearts. High-dose steroids not great for that scenario, right? So then you have to tease out here. Vigabatrin, also known as Sabril, very good seizure med. It's the #1 for kids with tuberous sclerosis, which is another cause of infantile spasms. I like it. It works very well. But you do need to have documented spasms. And the way I approach this with families is I talk about all 3 options, pros and cons, what people like and don't like, and I tell them, whatever you pick, if it doesn't work, we have to pick one of the others. And so the rules are pick a steroid or pick an anticonvulsant. And if one doesn't, you need to do the other. Don't do 2 steroids. Don't try zonisamide or Depakote or any of the regular seizure meds. They're just not going to stop this. Admitting them in the hospital, giving them benzos, it's not going to stop this. So you have to do these things. And because of the way things have changed, these all take several days. Prior authorizations, showing them the information, trying to get this sent to these folks' homes. So there's a delay even once we manage to get you diagnosed with treatment. But that's my infantile spasm area. So these videos, I won't show you too many. You guys have all seen these videos of things of this sort. But considerations of a psychogenic non-epileptic spell, really long duration with no severe consequence is deeply suspicious. So if you have a family tells you a 30, 40-minute generalized tonic-clonic seizure, you say, well, what ER did you go to? We didn't go to an ER. What problems did you have? No problems. That's pretty suspicious. It's another picture of what you would see. This kind of writhing sort of movement epilepsy doesn't do that. And I'm going to just kind of leave those off for a second, but talk to you about things I look for when I hear a story. Is it psychogenic or not? We always have to prove psychogenic spells, especially if they're often, okay? Eyes closed almost never happens in an epileptic event. Your eyes really ought to be open. Rolled back, deviated, that's all fine. But eyes closed, especially if you're seeing one and you're trying to open their eyes and they won't open them. That's too cognizant, right? So that's a suspicion there. Waxing and waning. So a seizure that really gets aggressive and then slacks off and then revs back up, that is very suspicious as well, okay? They really are getting tired, okay? The folks are getting tired. There's a lot of demand to do this. It's very exhausting. And then we all know the ones like certain triggers, like, well, every time she does this or every time he does that, he's going to have this seizure. So you need to figure out what those triggers are, but that's not as common. Usually there's no provoking cause. There's nothing big that just happened that people will tell you. Sometimes they don't identify any sort of stressors. But what I tell families, and I usually say there's electrical types of seizures and there's non-electrical types of seizures. This type is caused by non-electrical factors, be it chemicals or imbalances or life stressors. And the medicines we use for the electricity seizures are not going to stop this. They're just going to make you toxic. They're going to interact with other things. You can get all the side effects, but you're not going to get any benefit. Maybe placebo for a brief period of time, and then this will start again. And they can correlate, right? So non-epileptic and epileptic spells can exist in the same person, but that's very rare. 10%, maybe less. So age is a big factor here, like I said earlier. A teenager that presents with just frequent, sudden, prolonged spells, almost certainly going to be this. And even though this is a non-neurologic, or at least in my opinion, a non-neurologic entity, I'm not going to treat this. A psychiatrist or a psychologist will. They have to see us because they're not going to believe it's hard to believe. They need the test. They need to have this proven. They need to have this discussion. They need to have time to think and process. And also what happens if I have this conversation, usually it's in the hospital when I have this conversation, but if I have this hospital conversation, I have the same thing with conversion, pseudo-paralysis, pseudo-ataxia, pseudo-blindness, etc. If they don't believe me, I recommend a second opinion at a more, exotic location that will then convince them that that's what this is. Because if they're not convinced, they will not pursue the treatment that may help. So then everything gets started over. They get treated with a bunch of medications because they're going to urgent cares. They're avoiding their doctor because you told them you think it's psychiatric. They're avoiding me because I told them the same. And so they're trying to find someone who will convince them or they'll believe that. But that is the most common type of spell in an adolescent or teenager. So psychogenic spells are the more common type of seizures compared to an epileptic one. So then there's non-epileptic spells, which are just recurrent, strange things that really do sound like seizures but aren't. Breath-holding spells go into that category. A convulsive syncopal episode, for example. So if you get lightheaded, pale, pass out, and have some posturing, of course, it looks just like a seizure. And the trick is what happened before and what the scenario is. So I get overheated, pale, nauseated, collapse, and then posture. You want to know timelines, but that's hard to do because you can't time your child doing that. That's impossible. And the other thing is most people don't know what happened before because the child just simply collapses. So you don't notice anything until they collapse. So what do? I would just say that always think of the other organ systems. If we've kind of blown into your hospital patient room, did our test and said, oh, it's not neurologic, and we float away, think about what other organ systems on. I do try to suggest other workups, and it is sometimes a little bit broad because as a non-cardiologist, if I even think of that, I probably recommend more of that than is necessary because I'm not a cardiologist, and so I can't rule that out just on the story. But kids who collapse with no explanation, who's not a seizure, I think that's reasonable. I think apnea in a baby that's not seizure, pulmonology, central causes, those things are reasonable to look for. Oh yeah, the other thing to remember, psychogenic spells in teens, adolescents, much better prognosis than a grown-up. Not true if the family does not believe the diagnosis. If you haven't sold it and they haven't internalized that and pursued the treatment, their prognosis is not good. Not good. Especially, I haven't seen this anywhere, but if one conversion type morphs into a new conversion type, that's also, I would think, a poor prognosis. I've had a lot of like weakness people who don't have a neurologic entity who then morph into convulsive seizure type spells, who didn't address the first one, so then we have this other thing. Or they did and they just, this is easier, even if I say address it and I bring you to a psychiatrist, you see one, it's not always easy to find out the cause. What's the right medicine to make someone never be sad? You know, it's very challenging. So most kids grow out of seizures, basically. When you first see your first seizure in pediatrics, we try to find a cause. We don't want a cause. I tell everybody, I'm working very hard to find an answer and I don't want to find one. Because they all want to know why am I seizing, what's causing this. If I find a cause, most true causes, they're not reversible. They're malformations, gliosis, something that you're probably not going to grow out of. If you're idiopathic and have this and I can't come up with a good reason, your chances of growing out of this are very, very good. This number falls every year, so the group of ones we don't know why, that lessens every year. These are just, oh, that didn't play either. Consider yourself lucky, you skipped ahead. So things I think are concerning, prolonged seizure activity, obviously. Any recurrent focal seizure that came out of nowhere, especially in a toddler or somebody who, anybody who has frequent recurrent focal seizures, I want to know they don't have a mass. Like, I need that proven to me. No vascular lesion and no mass, and that makes me nervous. Frequent generalized seizures in an otherwise normal toddler who's also confused. The other thing you have to consider is autoimmune and paraneoplastic. They're not very common, but they exist. And I send Mayo Clinic panels. There's not a rule as to what kind of panel you send, but I send those in a kid who has fulminant recurrent seizures that just come out of nowhere. Focal deficits after a seizure are concerning because you don't know that they're reversible until they reverse, right? So at first you're just seeing not moving an arm or not moving a leg. You don't know if they stroked or had a stroke and that caused a seizure or bleed. So you do all these workups in the ED. Once they resolve, then that's better. So this is kind of, I only say this when people ask me what to do. Put them on the side, don't put anything in the mouth. To me, that's good panic instructions, right? That's palatable, digestible. I can do that when I'm panicking. Put them on the side, don't put anything in the mouth. Because your first impulse in a seizure is going to be to pick them up and shake them or try to, you don't know what's going on and you're just trying to get to your kid and get them to wake up. And so all kind of stuff happens. But keep in mind, adrenaline in a grown-up with a kid, you just want to put them on the side and let them have their seizure. If there's more than one person, especially if it's more than one seizure, I ask for someone to film it. No one films the first seizure. That would just be very bizarre. But if they have enough, they can. And just give people things to do. Call an ambulance. Get the diastat ready, etc. Rectal diazepam I give to anyone who I think is at risk of a seizure. Because the indication is for convulsive seizures. If I think you had a focal seizure, I'm going to give you that because what stops a focal seizure from becoming generalized? Medication, genetics. Your next seizure could be a big generalized seizure. And there's no side effect of carrying diastat in your purse. It's so I like to have it. I think it gives parents some control. They do make intranasal Versed, and some people use that, but that's not. Do you have any patients with intranasal Versed? Anybody? So basically that comes as a literal syringe with a needle. You have to draw up, then you have to put on an atomizer, and then you have to put it in their nose and shoot it up. And people who don't see seizures very often, it's impossible to be so cool that you're just measuring all this out. A lot of parents will stab themselves, break the bottle. Diastat's a good panic medicine. You just take the lid, you just take the cap off and put it in, and you're dreading giving it so much, you know exactly what you have to do, I think. Like, I think people fear, I hope I never have to give this. So right when they have to give it, they know what to do. Some people will mess up, or they most commonly went on vacation and didn't bring it. That's kind of the more common. A lot of people do 3 minutes now. I don't think many parents wait the full 5 minutes. It's pretty impossible. So this is free. This is the Epilepsy Foundation. Really anything you need, epilepsy.com is literally the website for the Epilepsy Foundation. There's a branch in Louisiana. It's in Baton Rouge. They have people who can come to schools and do teaching. They have a 90-something page PDF for parents of new diagnosis that they can read. There's message boards, hotlines, all kind of stuff. But these printouts I think are very good. So generalized seizure tells you what to do. Partial seizures. So I always laugh. The partial seizure kids are all cooler than the generalized people. They're not near as cool as these kids. But I think that the other safety thing people don't think about, I just remembered, is bathtubs. So you get a 3, 4, 5-year-old, you have them in the bathtub, and you're there, but kind of you take a call or you walk out. You don't do that ever with epilepsy kids. You just can't ever leave them with standing water without a person one-to-one. The other thing people forget about is big people, teenagers. Whoever's watching them in the water has to be able to get them out of it. So it can't just be a grown-up with a phone. It's got to be somebody lifeguardish who can get in a pool and pick up a 200-pounder and get them out. So consider that. In a bigger male patient, whoever's watching them in the water needs to be a legit swimmer. Now, I don't know how they would measure that or see, but it can't just be a regular adult. That would be challenging. So this is kind of that first part I said. First seizure, everything's normal. Your risk is pretty low. 24% it says. Some people say 30%. Way less than 50, so we don't start meds. But once you have 2, we're looking at 70% now. And that risk is the same for kids who are neurologically, right down here. Abnormal EEGs, prior neuro insult, etc. Your risk is very high. You need to be on medication. And there's no real difference in the duration. So like if you have a seizure and a year later have another one, still technically 2 seizures. Your risk of more is still 70%. You just don't have a bad epilepsy, I guess. You don't have very many, or you have myoclonics or staring seizures that no one's realized, and you're having seizures that people are missing, but you only have generalized seizures that are big enough to notice every so often. So lots of choices. There's like 30 anticonvulsants at this point. Keppra is the most commonly prescribed seizure med on the planet. Lots of reasons for that. There are side effects to Keppra, but we don't have to monitor blood work necessarily. It's a broad spectrum anticonvulsant. Most guidelines will tell you carbamazepine, dilantin, phenobarbital, still the oldies but goodies are the most commonly initial treatments. But long term, if you're going to be on it for years, those initial generation anticonvulsants have a lot more osteopenia type side effects, teratogenic side effects if you're talking about teens. And in dilantin at least, kids can't keep a normal dilantin. It's very impossible to keep a normal dilantin level in a child. In a grown-up, it'll stay smooth and easy. But in a kid, your level fluctuates all the time. So when you see kids on dilantin as little kids, that's usually not what most people would do. And so when you think about carbamazepine, you probably see lots of people, I've seen lots of people around here on carbamazepine. Most people I think now use a lot more trileptal, which is oxcarbazepine, sort of a similar mechanism, but usually better tolerated medication. Keppra I like mainly just because it treats all types of seizures. It doesn't worsen any type of seizure. Trileptal worsens certain types of seizures. So if I'm ambiguous, I see an EEG that needs, you have seizures, but I don't exactly know if you also have certain other types, trileptal can worsen some kinds. So we go through all these side effects when we start medicines on people. I tell them to talk to their pharmacist. I tell them to talk to everybody and think about these side effects and call me if they think of something later. Because when you're starting a medicine on your kid and it's going to be an everyday medicine, we treat 2 years. 2 years seizure-free is how long you have to treat fastest. So there's no course, which is another new concept for pediatric folks, parents, because they want a 14-day course, 20-day course, knock out this epilepsy and go on, right? But it's a two-year course and a normal EEG. So the medicine does not normalize EEGs in most cases. It just keeps those abnormalities from turning into a seizure. And so I can still, on EEG, see abnormalities. So I don't tend to redo EEGs a lot when you're on medicine and not having seizures. But before I wean you off, if your EEG is still active, I recommend going another year. Your risk of breakthrough seizure is super high. And so a lot of folks will end up not having seizures for 2 years, and they'll take themselves off medicine to see. But there's a pretty quick and safe way to just kind of cheat and see before you take the medicine away. So that's my whole Keppra spiel there, but then exceptions. Keppra does not treat absence seizures. It does not treat infantile spasms. And most people like to use these for partial seizures, but because of blood draws, I still use Keppra. But I tell families exactly what I just told you. A lot of doctors would start you on trileptal. If we start trileptal, we need to do this, this, and this. I like to start Keppra because of X, Y, Z. And then I let them pick. So seizure treatment, oh, that didn't work either. So basically that's a slide that shows that seizure treatment is meds, okay? After the first 2 meds, maybe 3, 80% of kids are going to be controlled. Ish. Those other 20%, almost never going to be controlled no matter what med you put on them. So they need to be referred somewhere for non-medicine management, ketogenic diet, VNS, or surgery. That doesn't happen very often. Only 5-10% of kids ever get referred out. We just keep trying new meds, and it's not going to work. 1%, 2%, that's literally your yield. But you may not even be a candidate for those other things. If you're not a candidate, then we try that 1 to 2%. But epilepsy surgery, if you're a temporal lobe, seizure-free forever, 70-80%. That's enormous. No one can do that with medication. Anyway, status epilepticus, I'm kind of running a little bit too long, so I'm just going to skip over status epilepticus. But keep in mind, secondary causes in a status patient, much higher. So you should look for infections, lights, all these things. So in a known epileptic who goes into status, we don't expect them just to go into status. So noncompliance, that's got to be the #1 cause. I don't know what that is, but not taking the meds, super common. So if they go into status, draw levels. And that's not to dose them, it's to see if they have a 0 level. If they have a 0 level, you've answered your problem. Infection, pneumonia, that kind of stuff will do it. Med changes is true, specifically stopping them immediately. So some kids will come in for surgery, for example, and they're NPO. And you don't have a choice. They cannot take it. That's not good, right? Sometimes they have these problems. Another reason I like Keppra, it's IV. So if you go into surgery or anything like that, if you're in the hospital for anything, ileus, you change it directly, milligram to IV. Same med. Super easy. It's available everywhere. If you do a trileptal, there's no IV formulation. So you're left just kind of treating benzos, hoping that they get their gut moving so you can put them back on trileptal that you worked up on for a year, and then you don't know where they'll tolerate. You can't just start back at a gajillion per kilo. So then you have this kind of quandary. Management, the only thing I would tell you guys about management of this, if you see patients, the big deal is don't underdose kids. There's recommended dosing. Don't give them baby dosing, like dose their weight. And don't wait. Don't wait for stuff to work. So that's more for the ER people. I don't know if we have any ER people here, but basically if you load this, you do benzos quick. Benzos don't work. You load an anticonvulsant. Phosphatidyl's usually the one recommended. All this other stuff, right? Respiratory depression, etc. So benzos #1, regular anticonvulsant #2, drip #3, basically. And it's boom, boom, boom. You load the Ativan and stuff quick. I usually recommend ordering the other stuff while you're loading with those. If those don't work, you need it at the bedside. You need to start treating this. Every minute that passes in status, you're less likely to actually control this without some issues. The longer it goes, the harder it is to stop. So one of the things we see a lot of times is either people are giving tons of benzos to non-seizures, so the seizure's over, the kid's now fighting everybody, and so you just benzo, intubate, because they get adult benzo dosing. Not good. Peds benzo dosing, if it doesn't stop it, give them legit dosing. Phosphatidyl's 20 per kilo. Phenobarb, only if you're okay with the breathing and it's a baby. I wouldn't really give a teen phenobarb unless you're ready to intubate, especially if you're going to give it a few doses. Keppra, you can give 60 per kilo as a single loading dose, max 4.5 grams. So when people want to know if 500 is too much for me or 750, we give 4,500 in a single IV dose to somebody with status. So you'll get pharmacy calls if you ever order that, but that is the recommended status dose, okay? And then we use things like Vimpat and valproic acid. I say this part should be preparing drips, right? Because sometimes it takes a while. You've got to get your pump and the drips. That's ICU stuff, not you guys. VNS is a good thing. You wave the magnet over to VNS. Anybody have VNS patients? Yeah. So VNS, the wave the magnet, the new VNSs, you don't have to do the magnet so much. The new VNSs actually monitor their heart rate, or they're supposed to. Depends on if your kids' batteries are out yet. Once their batteries come out, they're going to change that into the new one, which new is probably last 3-5 years. They measure heart rate and set a threshold. When their heart rate goes up, it stimulates you. So the rate of grand mal seizures and status has gone way down since they've done this. That they, even with small seizures, your heart rate goes up. And so at night, no one can wave anything. It detects that heart rate. They monitor that in the OR when they put it in. They synchronize it, and they'll change that threshold, right? So they set a standard threshold, but if yours needs to be adjusted, they'll make it more aggressive and it'll stim more. But they work. Not seizure-free. VNSs are palliative, not curative usually. I don't know if that relates to a lot of you guys. If they're here in hospital management, we'll help with that. Okay. So what I would say is any repetitive weird thing a kid does may be a seizure. That's the summary for that. And an EEG is probably reasonable. If it's always triggered by some behavioral thing, that's probably not. But if you're suspicious, an EEG is not a big deal. But if you do EEGs for migraines and things, we may find some things here and there that they don't have any seizure semiology, but we found something on the EEG. Now what do? Do you treat them with anticonvulsants for 2 years? Probably not. We repeat the EEG, we do something else, we find out an electrode back here was loose, or the kid was laying on the pillow like that instead of like this, and sometimes that happens. So I usually watch video and try to discern that. So your history, when you order the EEGs, I read that. I try to get the text to inquire that because that has a bearing on things, the likelihood. And you can always call, me or Jancy, happy to talk to you.